Welcome to CardioBuzz. In the previous episode, we discussed the conservative management of coronary disease. We explored the role of lifestyle interventions that genuinely make a difference, medications that can prevent myocardial infarction, heart failure, and death. These included lipid-lowering agents, anti-inflammatory drugs, diabetes medications, and therapies targeting obesity, as well as antithrombotic medications. We also touched on strategies that relieve angina. But in real-world practice, many patients with stable or chronic coronary disease require more than conservative management. Some patients may need revascularization of the epicardial coronary arteries. And today we focus on this invasive management. And we will address two major questions. What is the benefit of revascularization on top of medical therapy in stable chronic coronary disease? And the second question, for those who require revascularization, which approach is better? PCI, the catheter-based approach, or coronary bypass graft, which is the surgical approach?
Welcome to CardioBuzz, your one-stop shop for all things cardiology. We bring you the news, groundbreaking research, and the most recent guidelines. We interview the experts in the field and try to answer the most difficult questions of everyday practice.
But before we tackle these questions, it's crucial to agree on few principles that guide our practice. Medical decision-making is based on three pillars. Number one, the evidence. We live in the era of evidence-based medicine, not logic-based or intuition-based medicine. The lowest level of evidence comes from personal opinions, case studies, whereas the highest level of evidence comes from randomized control trials and meta-analyses. These provide us with statistically sound conclusions. And throughout the discussion, we'll examine the evidence from randomized control trials and meta-analysis. But evidence alone is not enough. We must also consider the available resources, which vary across different healthcare settings. For example, a patient with a heavily calcified coronary lesion requires specialized devices for treatment. If these tools and devices are not available, then PCI might not be feasible, and then we think of alternative strategies like bypass graft or medical therapy. The third pillar is the patient preferences. Even with strong evidence and sufficient resources, the patient values and preferences must guide the decision. Our role as physicians is to present the evidence, explain the advantages and disadvantages of each option, and allow the patient, along with their family, to make an informed choice, and this decision must align with the patient's values and culture. Even when we're trying to look at the evidence and the resources, the decisions made by physicians can be strongly influenced by multiple factors. The design of the healthcare system, whether the system focuses on productivity or on quality. The personal biases of physicians. Some doctors are naturally more conservative, while others lean toward invasive approaches. The interpretation of clinical trials. A single trial may have positive and negative endpoints, leading to various interpretations of the same trial. This variability reminds us that medicine is not an exact science. It requires wisdom and a patient-centered judgment. But trying to be objective, when we compare therapies for coronary disease, we need to look at specific endpoints for the comparison. And we have 7 critical endpoints. We compare therapies in terms of their ability to reduce death, myocardial infarction, stroke, heart failure, hospitalization, repeat revascularization, and of course, anginal relief. These outcomes will guide our discussions on medical therapy versus revascularization and PCI versus bypass. So let's start by the first question. Medical therapy alone or medical therapy with revascularization? And both strategies have valid arguments. PCI and CABG improve coronary perfusion, but on the other hand, they do not heal atherosclerosis. Atherosclerosis is a systemic disease that requires a systemic treatment. Another argument is that chronic coronary disease is usually a low-risk condition, and the risk of events is low, so medical therapy may seem to be sufficient. Also, angina may be relieved spontaneously without revascularization. And to make it even more complex, we have trials that support medical therapy as the preferred strategy, and other trials that prove that revascularization is beneficial when added to the best medical therapy. So which strategy is the best for the patient? Before we answer that, we need to know that this question does not apply for patients with left main disease. The left main coronary supplies 70% or more of the myocardium, so revascularization is almost always indicated. The second situation is heart failure or ischemic cardiomyopathy. This is an extreme form of coronary artery disease, and we have a special episode on that situation where we discussed the impact of revascularization on outcomes in chronic heart failure, the importance of viability assessment, and CABG versus PCI. I will post a link to that episode in the description. Then the question is, For patients who do not have left main disease, they are not in heart failure and their ejection fraction is more than 35, and they have a severe epicardial coronary stenosis defined as 70% or more diameter stenosis or 50% or more diameter stenosis with inducible ischemia, or a lesion that is physiologically significant with an FFR less than or equal 0.8 or an IFR less than or equal 0.89. In these situations, is medical therapy alone sufficient, or we need revascularization on top to improve the outcomes? So let's talk about the first outcome, which is angina relief. This is important for all patients, of course. And this part of the question has a clear answer. Revascularization is the clear winner. Almost all trials showed that revascularization outperforms medical therapy alone, earning it a Class 1A recommendation for patients with angina despite medical therapy. How about the other outcomes? How about death and myocardial infarction? When we look into the trials, the randomized control trials that compared medical therapy and revascularization, we have more than 20 trials. Famous ones, the Courage, Ischemia, the FAME, the BARI, the RITA, Orbita. We have more than a dozen trials. And these trials come with different inclusion criteria, exclusion criteria, and endpoints. So how to get the truth out of these trials? We turn to meta-analysis. Meta-analysis, as we mentioned earlier, is the strongest level of evidence. It combines results from multiple trials to reach robust conclusions. Meta-analysis is a systematic method that uses statistical techniques to combine different studies to obtain an estimate of the overall effect. And it gives larger trials a heavier weight in the analysis to inform us about the overall result when we combine all the trials together. And probably the most comprehensive meta-analysis that we have on chronic coronary disease was the one by Navarez et al. Published in 2021, where the investigators examined 25 randomized trials, including roughly 20,000 patients. And they compared medical therapy alone with medical therapy and revascularization. And here's what they found. They found that revascularization on top of medical therapy significantly improved cardiac death and myocardial infarction. Overall, cardiac death was reduced by 21%. Myocardial infarction, spontaneous myocardial infarction, was reduced by 20%. And interestingly, the benefits of revascularization became more pronounced over time. The longer the follow-up, the greater the reductions in death and MI. And the reductions in death was proportionate to the reductions of spontaneous myocardial infarction. And the possible reason for the survival benefit for long-term follow-ups could be due to the durable benefits of revascularization in contrast to the attenuation of medical adherence over time. So there was a strong association between reduction of MI and reduction of cardiac death. And the presence of multivessel disease at baseline was found to enhance the survival advantage of revascularization compared to medical therapy alone. So trying to answer the question of medical treatment versus medical treatment with revascularization, my own interpretation is that revascularization is important. It provides better angina relief, it reduces myocardial infarction, and reduces cardiac mortality. There are some caveats, of course, which give some sense to medical therapy alone, that the total myocardial infarctions did not change because there were some procedure-related myocardial infarctions, and the total mortality also did not change because as cardiac mortality is reduced, other causes of mortality tend to show on the surface. So again, medical treatment still has an argument, but I believe that revascularization on top of medical therapy is the best approach to prevent myocardial infarction death and to relieve angina. That's why in the latest European Society of Cardiology guidelines, in patients with an ejection fraction more than 35, revascularization improves survival, reduces death and spontaneous MI for patients with left main disease, multivessel disease, one or two vessel disease, and proximal LAD. Of course, this comes after informing the patient about the benefits, the risks, the consequences, and the alternative to revascularization in a lay language that the patient must understand. Then comes the second question, which is PCI versus CABG. We know the strengths and weaknesses of PCI and CABG. PCI has the advantage of being minimally invasive, faster recovery, quicker return to daily life. That comes at the disadvantage of being less durable with high rates of repeat revascularization. Where bypass has the advantage of longer term durability, especially with internal memory grafts, but it comes with the disadvantages of being invasive, requires longer recovery times, and of course it's a surgical procedure with wounds and the traditional surgical complications. And so when looking at the evidence that compares angioplasty and bypass, we need to remember that this evidence applies only to patients that are feasible for both approaches. There is no sense in comparing angioplasty versus bypass in a patient who has distal diffuse disease and no graftable targets. And there's no point in comparing angioplasty with bypass in a patient who has multiple chronic total occlusions that is not amenable to angioplasty. And again, it's recommended that we select the most appropriate revascularization based on the patient's profile, the coronary anatomy, ejection fraction, patient's preferences, and outcomes. And the decision for revascularization must be patient-centered, considering the patient's preferences, the cultural circumstances, and the social support for complex cases to define the optimal strategy. When PCI and CABG hold the same level of recommendation, of course we need a heart team discussion. All of these are class 1 recommendations. Eventually, the decision will boil down to two main factors: the anatomical complexity and the patient complexity. Patient complexity refers to the frailty of the patient, the number of comorbidities, the suitability of surgery. Anatomical complexity means the extent and the severity of coronary artery disease. And we need to evaluate both variables in an objective way as much as possible. To evaluate anatomical complexity, we have the syntax score. It has been developed from almost 20 years, and it's probably the best score we have to evaluate the anatomical severity of coronary disease. In an objective way, we look into the dominance, left dominance or right dominance, and then the epicardial coronary tree is divided into 24 segments. Then we look into each segment and we look at the lesion at that segment and we assign a score for that. This score is magnified when there's a total occlusion, when there's a bifurcation or a trifurcation, when it's an aorto-ostial lesion, when there's severe tortuosity and heavy calcification. And based on the summation of the anatomical factors of each lesion in each segment, we reach a final score. And then we have three zones. When the score is 22 or less, this is a low complexity disease. When the score is 32 or more, this is a high complexity disease. In low complexity disease, PCI is preferred. High complexity, CABG has the advantage, whereas in between 22 and 32, we need to consider other individual variables to guide our decision. Looking into the patient complexity, again we have objective scores. Probably the most famous is the STS score that looks into the type of the procedure, whether it is an urgent or an elective procedure, the comorbidities, the kidney functions, liver functions, the ejection fraction, the presence of heart failure, the presence of endocarditis, the presence of arrhythmia, associated valvular lesions or vascular disease. And when the score is higher, it means that the hospital mortality with bypass would be higher. And then based on the anatomical complexity and the patient's complexity or surgical risk, then we have four possible iterations. When there's low complexity disease, then PCI is preferred regardless of the surgical risk, because PCI, as we said, is simple and the patient can resume activities quickly. So PCI is the preferred approach for low complexity coronary disease. For high complexity coronary disease, of course, bypass, especially when the surgical risk is low. When the surgical risk is high, still we need to consider bypass, but PCI comes here, usually gets a weaker recommendation. So let's look into different scenarios. Number one, multi-vessel disease. Severe stenosis of 3 or more of the epicardial coronary arteries. We know from the meta-analysis of multiple randomized controlled trials looking at more than 11,000 patients, we see an advantage of coronary bypass in patients with multi-vessel disease only in patients with diabetes. In patients with multi-vessel disease and no diabetes, there's no significant difference between PCI and bypass. But when we look into longer follow-ups, more than 10 years follow-up, the mortality advantage of bypass over PCI tends to fade away at 10 years of outcome. So what do we learn? Bypass has an advantage, mainly in diabetes, but this advantage is usually lost over long-term follow-up. We've seen that in more than one trial. The FREEDOM trial showed that there is a survival advantage of bypass for multi-vessel disease in diabetes, but again, this survival advantage tends to fade away with follow-up. So considering the evidence and having a patient that is suitable for both revascularization modalities, diabetes mellitus is a key determinant factor. If the patient has diabetes mellitus, then bypass gets a class 1 recommendation. Unless he's high surgical risk, then PCI gets a class 2 recommendation. If there's no diabetes, then usually coronary bypass and PCI get an equal recommendation, but PCI of course in low intermediate complexity of coronary disease. Of course, this again should be a patient-centered decision. Left main disease In left main disease, the differences between bypass and PCI are clear. Bypass is associated with less spontaneous myocardial infarctions, is associated with less repeat revascularization. Of course, it's more durable, but it is associated with an increased risk of stroke. But when it comes to the total mortality, when we look again into the meta-analysis and patients with an intermediate complexity of coronary disease up to 31, then there is no difference between PCI and CABG when it comes for all-cause mortality in left main coronary disease. So how would we translate that into the patient's care? Unprotected left main without multi-vessel disease. So the anatomical complexity is usually not very high. Then CABG is okay, and PCI gets also class 1 when the anatomical complexity is low. But as the anatomical complexity gets higher, then PCI is downgraded from class 1 to class 2. That's for patients with isolated left main disease without multivessel coronary disease. If they have multivessel coronary disease and left main disease, by definition, this is a high complexity disease, so CABG gets class 1 recommendation. Unless the patient is a high surgical risk, then PCI comes as a class 2B recommendation. PCI in left main disease needs to be done by experienced operators with routine use of intravascular imaging, because we know that these two variables make a difference in the long-term outcome. Then we come to easier situations, two-vessel disease with proximal LAD. In this situation, both PCI and CABG are recommended to improve symptoms and outcomes. In patients when PCI is less feasible, for instance, a chronic total occlusion, recurrent in-stent restenosis, then CABG is recommended to improve the symptoms and reduce the repeat revascularizations. For two-vessel disease without proximal LAD, it's easy. PCI is recommended to improve symptoms and probably reduce MI. In those patients who are not amenable to PCI, CABG may be considered, but it gets a class 2B recommendation. So to conclude, the question of medical therapy alone versus add-on revascularization. Revascularization reduces MI, reduces cardiac death, and improves angina. PCI or bypass. PCI for low complexity disease, bypass for high complexity disease. Unless the patient is a high surgical risk, then PCI gets a class 2 recommendation. That was all for today. In the coming episode, we'll discuss angina or ischemia with no obstructive coronary arteries, INOCA or ANOCA. We'll discuss the different types, the diagnostic tools, and the treatment. So stay tuned and see you in the coming episode.
If you enjoyed this episode, don't forget to hit the like button, share, and leave a comment. Make sure to subscribe to the channel and hit the notification bell so you never miss an update. Thanks for your support. See you all soon.